All right, so good evening again. We're gonna look at acute coronary syndrome, but before we go into the pathophysiology of acute coronary syndrome, clinically, when we talk about acute coronary syndrome, we talk about acute ST segment elevation myocardial infarction. So a heart attack, acute ST segment elevation heart attack. And then we have acute non-ST segment elevation heart attack. So those two types of heart attack, where you have ST segment elevation and the non-ST segment elevation, they are a part of the acute coronary syndrome um, continuum. So when we talk about a heart attack, it could be either ST segment elevation or non-ST segment elevation. And under the umbrella of acute coronary syndrome, we also have unstable angina. Okay, so unstable angina and sudden cardiac death is also a part of acute coronary syndrome. So it's a fairly large uh, topic, and it covers, almost all the acute presentation in terms of atherosclerotic coronary artery disease. So the ST segment elevation MI, the non-ST segment elevation MI, sudden cardiac death, and unstable angina. So how this comes about? What is the underlying abnormality that gives rise to acute coronary syndrome? So the pathophysiology of acute coronary syndrome, if you look at the blood vessel lining, there are different layers to the blood vessel line. We have the intima, the media, the adventitial layer. Um, you tend to get plaque formation in the wall of the arteries. And these plaques usually form at fairly early age. They usually form at fairly early age. So if you if you look if you were to look in at the blood vessel wall of fairly um, young individuals, you can see these early stages of atherosclerosis. So these plaques usually form when you have oxidized LDL. So, cholesterol, we divide cholesterol into the bad cholesterol, which is the LDL, low density lipoprotein cholesterol, and the good cholesterol, which is the HDL, high density lipoprotein cholesterol. The bad cholesterol, when it's oxidized, it's taken up into the arterial wall. It is engulfed by macrophages, and this give rise to the formation of plaque. And these plaques we call the atheromatous plaques. So the bad cholesterol, which is, it first has to become oxidized, and then when it is oxidized, then there's an attraction between the oxidized LDL, which is the bad cholesterol, and the macrophages. The macrophages tend to eat it up, and then these form foam cells. Okay, these foam cells get larger and larger, and until you get a fairly large plaque. But remember, this process starts, at a fairly early age. So, the risk factors for coronary artery disease, if they're present, then they make this process uh, uh, occurs more readily, or more or easier. All right. So we talk about the formation of the plaque in the arterial wall. It's just the oxidized LDL, the bad cholesterol, oxidized, taken up into the arterial wall. You get these so-called foam cells, which get bigger and bigger, and then you have the plaques. Now, for you to develop an acute coronary syndrome, you have to have a vulnerable plaque. And when we say a vulnerable plaque, it is a plaque that is ready to rupture or burst. And a vulnerable plaque, so we look at how the plaques are formed. Now we're going to look at the vulnerable plaque. These are plaques that are going to rupture. And plaques that are going to rupture, they tend to have a thin fibrous cap, a high lipid core, that means the content inside the plaque is rich in lipids, and there tend to be inflammatory process going on. And you can also get what we call intraplaque hemorrhage, bleeding inside the plaque. And when you have a vulnerable plaque, this plaque will rupture, burst. When the plaque bursts, it releases materials which cause blood to clot on top of the plaque. And sometimes you can get complete blood vessel occlusion. The lumen is completely occluded, or you can get partial occlusion. So again, the spectrum of conditions that we see and we call acute coronary syndrome, unstable angina, and that is when you have a blockage and you have some type of discomfort in the chest. So again, the discomfort that you get is not necessarily pain as you know it. It might be a tightness, a pressure, a burning, a squeezing. You know, some patients have different description for these discomfort. You know, a very common one is it's like a elephant sitting on my chest. If I'm seeing a patient and a patient tell me that it's like an elephant, I don't want to hear anything more. Elephant on the chest to me is an acute coronary syndrome. All right, so so when they have unstable angina, there's a blockage. You rupture the plaque, and it's the vessel is not completely occluded, but there is obstruction to blood flow, and the patient will complain of chest discomfort. So if they had angina before, what makes it unstable? They may have more frequent episodes. They may have episodes with less exertion or activity, um, or it may be associated with shortness of breath, something like that. And then we spoke about the non-ST segment MI, non-ST segment elevation myocardial infarction. So when we look at heart attacks, you know, so heart attacks can be non-ST segment elevation MI. We call it non-STEMI or NSTEMI, or it can be a ST segment elevation heart attack, STEMI. And it's basically what it is. When you look at the ECG or the EKG, you look at the ST segment. If it's elevated and the patient is having a heart attack, then it's ST segment elevation. If it's not elevated and the patient is having a heart attack, then it's a non-ST segment elevation. Okay, and then sudden cardiac death because of the blockage. These patients die sudden. If they're resuscitated, then then they're resuscitated sudden cardiac death. And some of these patients have sudden cardiac death, uh, and it's witnessed. If it's witnessed and they're resuscitated, they come to the hospital, and sometimes they do very well. So these are the spectrum of acute coronary syndrome. All right, so we touch a little bit on the pathophysiology. So we discuss how the plaques get formed, and then the plaque growth. The plaques can grow because of repeated rupture and healing. Remember what we said, when the plaque rupture, then you have blood clot on top of the plaque. So if you have repeated rupture and healing, then the plaque will get larger and larger and larger. Okay? The clotting on top of the ruptured plaque don't necessarily have to cause complete occlusion. If you get complete occlusion or complete blockage of the blood vessel, then you can get a STEMI, or ST segment elevation MI, or a non-STEMI. All right. You can also get bleeding in the plaque, and then the plaque grows. Okay. So the growth of the plaque probably is more commonly due to these phenomenons. All right. So again, if you look at the normal blood vessel is supposed to have a smooth lumen, okay, uh, and this is longitudinal cross-sectional area of the blood vessel. So when you have the atherosclerotic plaque, okay, the plaque is usually in the media of the arterial wall, and it gradually grows. Remember what we said, the growth can be due to rupture eelin, or bleeding inside the plaque, okay? If the obstruction is more than 70% of the lumen, so if the plaque is occupying more than 70% of the lumen, then it's gonna cause significant reduction in blood flow. Okay, if you look at it in cross section, the plaque is right here. You can see that the lumen of the artery is narrowed. So a significant plaque usually will obstruct about 70% of the arterial lumen. Um, so again, just going over the same process, the atherosclerotic plaque, atherosclerosis, the LDL, which is a low density lipoprotein cholesterol, becomes oxidized. This oxidized LDL is absorbed into the arterial wall. The oxidized LDL attracts macrophage. Macrophage is a type of white cell which engulf or eat up these oxidized LDL. You have other inflammatory cells taking part as well. So this process, it's gonna release what we call cytokines, and these cytokines attract monocytes, and these monocytes become the macrophages. So the process begets itself. When the process starts, cytokines are released. Uh, these are like hormones or chemicals. There are more chemicals that will cause the attraction of monocytes, and then the monocytes will transform into macrophage, which eat up more oxidized LDL. And again, the early atherosclerotic process we call the foam cells, which is just macrophage overladen with oxidized LDL. So increased macrophage activity, that is eating up of the oxidized LDL, can cause what we call macrophage-induced enzymes. And this macrophage-induced enzyme will erode away the fibrous membrane and give rise to a thin cap. So the same process can form vulnerable plaques. Remember what we said about vulnerable plaques? Vulnerable plaques tend to have a thin cap and a high lipid content. So when you have a vulnerable plaque and the plaque ruptures, the rupture of the plaque is due to the stretching and contraction. Remember, the arterial wall, the arteries contract and relaxes. All right. So when the plaque rupture, the material inside of the plaque release clot promoting substance. It is the material that is contained within the plaque it promotes clotting. It's more of a platelet plug than real clotting, however. All right. So again, if we look at the process, this is the blood vessel lumen. In the wall, you have the plaque. If it's a vulnerable plaque, high lipid content, thin wall, the plaque ruptures, the material that is released will cause clotting. And it's not the classic clotting as we know it, but it's more of a platelet thrombi, which occludes, which coalesce on top of the ruptured plaque and block the arterial lumen. All right. So the thrombus, or the clot that is formed, can be occlusive. That means it can completely occlude the blood vessel lumen, or it can cause vasospasm. That is, the blood vessel goes into spasm. Or you can get distal embolization. That is, the clot or the thrombus breaks off and travels distally. So if you know the anatomy of the blood vessels around the heart, this is the right coronary artery, and it gives off the acute marginal branches. And then this is the left main coronary artery. You get the left anterior descending coronary artery, which comes in the front, and the left circumflex, which loops in the back. So these are the three main blood vessels around the heart. And it's the atherosclerotic plaque forms within these blood vessels. This is an angiogram. This is an angiogram looking at the left system. This is the left main coronary artery. This is the left circumflex coronary artery, and this is the left anterior descending coronary artery, okay, which goes around the apex of the heart. And this is a big, what we call diagonal branch. So if you look in this angiogram, you can see that the blood vessel lumen, because all you're seeing is the lumen, the blood vessel lumen looks fairly decent. I don't see any obstruction. You can see it's nice and clean. This is an angiogram of the right coronary artery, and you can see that the lumen is nice and clean. This is what you want to see. Okay, when you do an angiogram, this is what you want to see. All right, so this is an angiogram showing left anterior descending coronary artery occlusion. So again, your catheter, this is the catheter we use, and this is the left main. We just inject dye into the left main, and it outlines the blood vessels. This is the left circumflex right here, because the left main coronary artery divides into the left circumflex and the left anterior descending coronary artery. If you look right here, you see a very, very narrowed area. Okay, this narrowed portion of the blood vessel, this is where the blockage is. And if you're just going to eyeball this and give a percentage, this is over 90% occlusion. Okay, and then the blood vessel reconstitute right here, and it looks fairly decent, apart from just this significant occlusion right there. If this blood vessel completely blocks off, then all the muscle supplied by this blood vessel here will die. So, if this patient comes in with either unstable angina, non-ST segment elevation myocardial infarction, or ST segment elevation myocardial infarction, or sudden death, if this patient comes in with acute coronary syndrome, you need to fix this as soon as possible. All right, so this is another angiogram. Again, your catheter is in the left main. You inject the dye. This is the left anterior descending coronary artery right there. This is the left circumflex, and you can see this blood vessel comes. There's an abrupt stoppage of the vessel right there, so you have an occlusion right there. Okay, the blood vessel is supposed to come and continues down. All right, so this is the right coronary artery. You can see that there is an obstruction in the mid portion of the right coronary artery. So how do we make the diagnosis of acute coronary syndrome? Remember that acute coronary syndrome is one of the leading causes of mortality and morbidity. So it's important for us to make the correct diagnosis. So just like anything in medicine, you need to take a proper history, a good history. You need to examine the patient, and then you need to do a few tests. The test that you need to do if you're going to diagnose acute coronary syndrome is your electrocardiogram, your ECG, EKG, other tests, blood tests. These are what we call biomarkers. These are substances that are inside the myocytes, the muscles. These are substance that is within the heart muscle itself. And when the heart muscle dies, it releases the troponin. It releases, you know, not so much your BNP, your pro-BNP, but creatinine kinase, LDH, stuff like that. The marker that we commonly use today is troponin, but there are other markers, okay? Creatinine kinase, myoglobin, so forth, so on. So these are additional tests that will help us to make the diagnosis of acute coronary syndrome. So when someone comes to you and you're taking the history and you talk about chest pain, a lot of patients will say, but doc, I don't have any chest pain, because what you're calling chest pain and what they're calling chest pain is completely different. For them, a pain is a sharp stabbing something, whereas, when you have an acute coronary syndrome, you're going to have a heaviness, a tightness, a pressure, or a burning, substernal pressure, tightness, burning, heaviness. So again, once and I've, patient comes to me, say, doc, it's like an elephant sitting. That elephant has never failed me in my diagnosis. Okay, that elephant is huge, and when once they tell you that, it's almost always acute coronary syndrome. All right, and that discomfort gets worse when they exert themselves. Okay, the discomfort also can radiate to the jaw, to the shoulder, down the arm. So those are information you're gonna try and elicit. Okay, so the discomfort, not necessarily pain. Is it associated with shortness of breath? Is the patient diaphoretic? Radiation of the discomfort? Where is the discomfort located? Okay, does it go to the patient back? Increase with activity? How long the discomfort lasts? So you need to know everything about that discomfort. Okay, again, shoulder, arms, neck, jaw, back, radiation. Is it associated with shortness of breath, nausea, diaphoresis? Patient always with acute coronary syndrome, a lot of these patients are wet because of their diaphoretic. Again, when we talk about unstable angina, which is a part of the acute coronary syndrome spectrum, unstable angina, new onset chest discomfort, on the Canadian classification score of 3, worsening symptoms. So they usually have, a little discomfort. No, this is much more severe, or it's lasting longer, more prolonged, severe with less exertion. So these are what makes it unstable. Okay, new onset, worsening, more prolonged. All right, then this is the Canadian Cardiovascular Society scoring system. So again, the Canadian Cardiovascular Society angina grading scale is commonly used for the classification of the severity of the angina. Okay, so when we talk about a class 1 using the Canadian Cardiovascular Society angina grading scale, a class 1 angina only during strenuous or prolonged physical activity. So you have to do a lot of work to bring it on. Whereas your class 2 with slight limitation with angina occurring during vigorous physical activity. Okay, so you don't have a lot of limitation from the angina, but vigorous activity brings on the angina. Whereas the class 3, symptoms with everyday living activity, your regular daily stuff that you do, going to bring on the discomfort. Okay, and there's more limitation with moderate activities as a class 3. And then class 4 angina, inability to perform any activity without angina, or if you have angina at rest, or if you have severe limitation. So class 1 through 4, 1 is the least angina discomfort, and then 4 is the most severe. All right, so physical examination, you're not going to get a whole lot from your physical examination. You still have to do it because if you get stuff, then it's huge. Okay, the physical examination may be completely normal. Again, diaphoresis is a very significant uh, accompaniment of acute coronary syndrome. Patients is wet, they're sweating quite a bit. Uh, these patients, I mean, will have peripheral artery disease because the same atherosclerotic process may occur in the lower extremity. You know, the patient may if when you check the pulse, the lower extremity pulse, they may be diminished or absent. All right. Uh, Listen to you may get what we call a S4 because the heart is stiff. Okay, the heart is stiff, and you might get S4 gallop. Mitral regurgitation if the muscle, the papillary muscle is involved, the proper functioning of the mitral valve, you're not going to get proper function of the mitral valve, so you get mitral regurgitation. And then you might get rales or crackles in the lungs because the heart muscle is not pumping adequately. So you get fluid in the lungs. Okay, so these are stuff that you can get. Uh, your electrocardiogram, this sometimes is extremely important, and well, not sometimes, it's always important. It may be normal, however, so you have to bear that in mind. So if the patient has classic uh, symptoms, okay, and risk factors, we didn't go into risk factors, but the more common risk factors for patients who develop acute coronary syndrome: hypertension, diabetes, dyslipidemia, cigarette smoking, family history. Those are the five most common risk factors. So, so if the ECG is normal or the EKG is normal, it's maybe normal because the process just starts and it takes a little time for the ECG to become abnormal. So you have to bear that in mind and repeat your ECG, say 15 to 30 every 15 to 30 minutes. You might have to do it more often than that. So, you know, you don't just come and everything looks okay, you walk away. No. If you get a classic history, you have to stay with the patient because it may be very early in the evolution of this heart attack. Okay? So the ECG may be normal if it's early or if it's a left circumflex occlusion. So that's why you want to repeat it every 15 to 30 minutes. Sometimes all you may see is T-wave inversion because remember what we said, you may get ST segment elevation. You may get ST segment elevation, or you may not get ST segment elevation. If you don't get ST segment elevation, then you may get what we call T-wave inversion. The T-wave may be inverted, or you may get what we call hyperacute T-wave. The T-wave look very peak, looking like hyperkalemia, or you may get ST segment depression. So, you know, the reason why you want to separate your heart attack into ST segment elevation and your non-ST segment elevation, the treatment is slightly different. So you have to bear that in mind. So if it's a STEMI, this is ST segment elevation, a myocardial infarction. A myocardial infarction is a heart attack. So if it's a STEMI, it could be either an inferior wall STEMI, an anterior wall STEMI, a posterior wall STEMI, or a combination of these. Okay? So this is what a normal 12-lead ECG looks like. You know, everybody knows what a normal ECG looks like. P wave followed by you have your QRS and your T wave, the ST segment, which is this portion right here is on the same level as your PR segment. So, everything is straight up. So this is a normal ECG. However, if the patient has an inferior wall STEMI, ST segment elevation, you look in the inferior leads, which is leads 2, 3, AVF, you can see that the ST segment is pushed up. Okay? So only in the inferior leads you have the ST segment pushed up. And what is classic, if you look in the anterior leads, which is, probably in V2, V3, there is ST segment depression, and even the lateral wall. Okay? So, it's not a fluke. Okay? When you look in the anterior lead, you get your ST segment depression. Okay? But this is an inferior wall STEMI, ST segment elevation, as opposed to your anterior wall STEMI. When you look in the anterior leads, which is your leads 2, 3, your V2, V3, V4, V5, so your anterior, this is actually, when you look at V5 and V6 is actually your lateral leads. Your true anterior leads is leads V2, 3, and 4. So you can see that the ST segment is elevated in the anterior lateral lead. So this is, classically anterior lateral STEMI, anterior lateral STEMI, because it involved the lateral leads. And why this is an acute heart attack, if you look in the inferior leads, you get some depression. Okay, so the leads, the portion of the heart which is opposite to the heart attack, you'll get some changes as well, not elevation, as opposed to your posterior wall STEMI, posterior STEMI. This is a little bit more difficult to diagnose, but the most classic one, you have your inferior wall STEMI, and then when you look in your anterior lead, you have significant ST segment depression. Or you can have your ST segment elevation in the inferior leads, and then you have prominent R waves in V1 and V2. So these are your STEMIs, ST segment elevation, myocardial infarction. So you need an ECG to make that diagnosis, as opposed to your non-STEMI. With your non-STEMI, you're just going to get ST segment depression, or you might have what look like a completely normal 12-lead ECG. But probably more classically, you get ST segment depression. You can see your ST segment is depressed. Okay, so these are acute events. Or you can get hyperacute T wave. These T waves are peak. They look like, patients has hyperkalemia. So hyperacute T waves. This is another EKG change that suggests acute heart attack. Now, Harvey infarct is a very important subset of your inferior wall heart attack. So patients who have inferior wall heart attack, ST segment elevation leads 2, 3, AVF, inferior wall heart attack. About 1/3 of these patients will have what we call a RV infarct. And the importance of a RV infarct is that the right ventricle is infarcted, so it's not contracting properly, and therefore it's not pumping blood into the pulmonary circuit. And as a result of that, your cardiac output is going to fall, and the patient is going to be hypotensive. So these patients, when they come to the emergency room or the intensive care unit, they're usually hypotensive. And because a lot of us practice knee-jerk medicine, patients has a heart attack, so they're supposed to be on this, not looking at the bigger picture that this patient has a Harvey infarct, and if you use your regular medicine, you can cause more harm than good. So how you diagnose your RV infarct is they come with an inferior wall heart attack, ST elevation leads 2, 3 AVF. But when you look at what we call V4R, they have ST elevation in V4R. V4R is a slightly different lead placement. Instead of putting the lead on the leads on the left side of the chest, all of us know how to put ECG leads on, instead of putting them on the left side of the chest, you put them on the right side of the chest. So you put them on the right side of the chest the same way. And when you look in the V4, so this is not regular V4, but V4 hard because you put it on the right side, you're going to see ST elevation in the setting of an inferior wall heart attack. This clinches the diagnosis. You do not treat these patients with nitroglycerin, okay? You'll make them worse. So these patients, you give them fluids or dobutamine. All right, so what are the biomarkers? What is the blood test that's going to help us to make the diagnosis of acute coronary syndrome? The one that we use predominantly today is troponin. This is a biomarker which resides in the muscles, the heart muscle. And when the heart muscle dies, it is released. Very, very sensitive and somewhat specific. Very sensitive and specific, upwards of 90%. So troponin, most sensitive and specific. Okay, very sensitive and specific. The isoforms of troponin, we have troponin T and troponin I. It is usually released about 2 to 4 hours after the injury, that is the heart attack, the heart muscle damage. 2 to 4 hours, you're going to get your release of your troponin, and it persists for up to 7 days. So, it's very important. We used to use creatinine kinase, CKMB. There are different isoforms. This CKMB, it's the isoform in the myocardium. It persists for about 2 to 3 days. A long time ago, we used to use LDH, lactate dehydrogenase. But the one that is specific for the heart muscle is LDH1. Okay, LDH1 isozyme. So it was not specific, however. All right, so troponin, make all of these things obsolete because troponin is very sensitive and very specific. Myoglobin is not specific, but it rises very, very early and it falls rapidly as well. So if you look at the graph of the biomarkers in terms of days after the onset of the heart attack, you can see the myoglobin, very shortly after the myocardial injury, the myoglobin goes up. Also the creatinine, the CKMB, but the CKMB lasts only a few days. But your troponin, after about 2 to 4 hours after the injury, it rises, and it has a normal distribution. Is that after the injury, it's gonna rise to a peak and then it falls off. Okay, so this, so if the patient if you have a troponin which is what we call flat, day 1, day 2, day 3, it's the same level, it's probably not a heart attack because you're supposed to get a normal distribution. It's supposed to go to a peak and then come back down. Okay, all right. What are the objectives to the treatment of acute coronary syndrome? Of course, symptom release. The patient is having discomfort. The patient is uncomfortable, so you have to treat the symptoms. You have to reduce the infarction size. That is, you have to reduce the amount of dead muscle that is gonna that you're gonna get. So you're gonna reduce the infarct size. You're gonna restore vessel patency. That is, you're going to restore the vessel to as close to normal as possible, and you're going to try and improve survival, decrease death. Okay, so these are the objectives of treatment: symptom relief, reduce the size of the heart attack, and improve survival. We have different risk stratification system. We have the TIMI risk score and the GRACE risk score. These sort of tell you how sick the patients are, and then probably how aggressive you need to be. So the TIMI risk score looks at the risk of death and ischemic events at 14 days. And it's mainly unstable angina and non-STEMI. And these are the things we use to put the patient in a risk category, the age of the patient, whether they use aspirin, the amount of change on the ECG, risk factors. Okay, and then if they have a score of 0 to 1, the risk is 4.7, a score of 2, risk of 8.3, up to a score of 6 to 7, and the risk is 40.9%. Okay, so it put the patient in a category, tell you how sick they are. You can go through different mnemonic, and the Grace risk score, the same thing, tell you how sick they are, and specifically the Grace risk score tells you the in-hospital and 6 months to 3 years mortality. So it gives you an insight into how well the patient is going to do in the hospital, 6 months to 3 years after they had a unstable angina or non-STEMI. The GRACE stand for Global Registry of Acute Coronary Events, and we plug certain information in. It's not something you calculate yourself. You have a app that will do it. You use the age, the heart rate, systolic blood pressure, creatinine, heart failure. You plug it into this app and it gives you the score. So the early management of acute coronary syndrome, the patient comes into the emergency room. Of course, you're going to give them oxygen. I know this is very difficult to see, but you can just listen to me. When they come into the emergency room, if the pulse ox is less than 90%, you give them oxygen. That's straight up. Coming with chest discomfort, we usually give them sublingual nitroglycerin. We'll give them every 5 minutes for a total of 3. And if they're still having chest discomfort, then we use an IV nitroglycerin. Okay, you put up your IV nitroglycerin, and especially if their blood pressure is elevated, then this is really good. Very important today, you have to talk to the patient, about their use of what we call phosphodiesterase inhibitor, your Viagra, your Cialis, stuff like that. It's very important because you don't want to give them nitrates and they had recent use of these medication because it can cause death. Okay, so they come to the emergency room, they're having chest pains, you give them IV morphine. It's reasonable to give them IV morphine for pain relief. Okay, what you don't want to do is give them NSAIDs. You don't want to give them Motrin and all that type of thing. Okay, in the emergency room or the intensive care unit, you want to use beta blockers, and beta blockers is your metoprolol, your carvedilol, stuff like that. You want to give them that early, especially if the heart rate is up. Okay, the beta blockers that were shown to be beneficial in these patients is your metoprolol succinate, carvedilol, and bisoprolol. We tend to use the others, but the ones that in studies that add mortality benefit is your metoprolol succinate, carvedilol, and bisoprolol. But however, remember that there can also be contraindication to beta blockers. If the patient heart rate is low and they have all type of blocks, you don't want to give them beta blockers. If the patient is wheezing up a storm, beta blockers can make that worse. So you don't want to do that. You have to be careful about calcium channel blockers. Certain type of calcium channel blockers are contraindicated. Okay, your calcium channel blockers that are contraindicated, your cardizem and verapamil. You don't want to give these patients those medications. So that's your early management. Now, patient comes in with acute coronary syndrome. You might want to do what we call a early invasive or ischemic guided management. And what we mean by that is you take the patient to the cath lab, you do a cardiac cath, you put a stent in, and the patient does well. Um, so you want to do immediate invasive management, that is within 2 hours. If you use a nitroglycerin, your IV and stuff, and the patient is still having symptoms, it's best to take the patient to the cath lab and see what's going on. Um, Also, if they have VT, ventricular tachycardia, or ventricular fibrillation, you want to open that vessel. And if you look at your TIMI, so your low risk patients, you can look at your score, your TIMI score, your GRACE score, and you can risk the patient, put them into risk category. Um, so if you have a GRACE score greater than 140, you want to probably take the patient to the cath lab and see what's going on. This is for unstable angina and non-STEMI. All your STEMI patients you're going to take to the cath lab. So all your STEMI patients you're going to take to the cath lab. All right. So we're not going to go into that, but there are special considerations, so to speak. As I say, you have to be careful about calcium channel blockers. You probably should stay away from your diltiazem, that's a cardizem, and your verapamil. Okay, you can give them your statins. Okay, and you can discuss smoking cessation, stuff like that. Um, okay. All right. So, as mentioned before, your patients with STEMI, ST segment elevation, myocardial infarction, all these patients should be taken to the cath lab. But you want to take them to the cath lab as soon as possible. We talk about time is muscle, because the longer the blockage continue, the more muscle the patient, heart muscle the patient is going to lose. So time is muscle. So you want to get them to the cath lab and open the blockage as soon as possible. So the early management, the nitroglycerin, the aspirin, the stuff, you give them all of that, just like you do your unstable angina, your non-STEMI. We tend to do what we call dual antiplatelet therapy, especially if you're going to take them to the cath lab and you're going to put a stent in. So you give them aspirin and clopidogrel, which is Plavix. Today we're using more Brilinta. Okay, so you want to give them two antiplatelet drugs, because remember we said when the plaque ruptures, it's mainly a platelet plug which you know goes on top of that, and then when you put your stent in, you want to prevent what we call stent thrombosis, blockage of the stent. So the dual antiplatelet therapy is what is recommended. So it's either aspirin plus your Plavix, which is clopidogrel, or aspirin and ticagrelor, which is Brilinta. Okay. For females with low risk feature, you should undergo early uh, with low risk feature. They should not undergo early invasive management. So if it's a female and she is not having a lot of chest pain, enzymes are not elevated, and you look at your TIMI risk score, your GRACE score, and she has low risk feature, you probably don't want to take her to the lab. No benefit if the hemoglobin is greater than 8 grams per deciliter. Um, you don't want to give them blood transfusion unless it's less than 8 grams. All right. Uh, do not give beta blockers to patients with recent cocaine or methamphetamine use. So I can see this. This is a nice exam question for people who do exams. Do not give beta blockers to patients who have a recent cocaine or methamphetamine use. Okay. This is going over the management that we discussed before. Again, when we talk about platelet activation, um, when you have damage to the endothelium. The bottom line is that platelet is one of the major component of of a heart attack, and so you want to attack the platelet activation from multiple sites. So that's why we recommend dual antiplatelet therapy. A clopidogrel or a Brilinta and aspirin. You remember the coagulation cascade is different from the platelet activation. So there are different things here. So, all right. Another thing is if the patient is having classic signs and symptoms of a heart attack and they have a left bundle branch block in the ECG, you have to treat them like a STEMI. Okay? And patients with posterior wall MI, remember we showed posterior wall MI, they have an inferior wall heart attack, but when you look in V1 and V2, you have prominent R wave, or you might have significant ST segment depression. You're going to treat them just like a STEMI. It has been shown in multiple studies that percutaneous coronary intervention, that stenting, is better than fibrinolytic therapy. So when we treat these patients, we can either use a medication that breaks up the clot, or we can put a stent where the obstruction is and open the stent. Okay, so if this is the blockage and the blood clots on top of the plaque, okay, so the plaque ruptures, the blood clots on top of the plaque. So we take the patient to the cath lab right away, and then we deploy the stent, and we remove or deliver system, and we leave the stent in place, which squashes the plaque onto the wall of the blood vessel. So this is what percutaneous coronary intervention looks like. So for STEMI, you want to take the treatment that you want to give to these patients is a stent. You want to put a stent in. That's what you want to do. Okay, percutaneous coronary intervention. Ideally, you want to do that less than 12 hours after they start having chest discomfort, so class 1. So if the ischemic symptoms is less than 12 hours and there's contraindication to giving your clot busting medicine, you put your stent in. If the patient is in cardiogenic shock, that is, the cardiac output is very low, the blood pressure is very low, or they're having acute severe heart failure, you want to take them to the cath lab and put a stent in. Essentially, almost all your patients with the ST segment elevation heart attack, you want to take them to the cath lab as soon as possible and put a stent in. Okay? And the bottom line is, and okay, so we have some timeline, because remember what we say, time is muscle. So if once a patient hits the emergency room and you determine it's a heart attack, you should have a stent in that blood vessel within 90 minutes. Okay, that's a standard of care. All right, so you don't have time to waste. As soon as the patient hits the emergency room, you know it's a heart attack, you alert the team, and everybody should be there on board, and within 90 minutes you get the stent in. If the patient goes to a hospital and that hospital is not capable of putting a stent in, they should be able to determine that the patient's having a heart attack, and the patient needs to be in and out of that facility within 30 minutes. In and out of that facility within 30 minutes. And you're going to transfer them to a facility that can do a stent, but that facility will be alerted, and that patient should have a stent in place in less than 2 hours. Okay, so even though they end up at a hospital that can't put stent in, they should be able to get the patient in and out of that facility within 30 minutes and then get them to a facility to put the stent in, and that should be done in less than 2 hours. Okay? If you cannot get them to a facility, say because of distance or transportation is not available or whatever, then and it's going to take more than 2 hours to get the stent in from the facility that cannot do the stent, then you need to give them thrombolytics. Okay, you need to give them clot busting medicine and then transfer them. All right, so it's very important. These timelines are very important. All right, and there are different type of stents, where drug-eluting stent, bare metal stent. It doesn't matter. You need to get them to a facility that can put a stent in. All right. If you're in a facility that all you have is clot busting medicine, we call fibrinolytics, or you might be in an institution that, or in a country that cannot cannot do percutaneous current intervention, then thrombolytics is a very good second option. Okay, these are clot busting drugs, and there are different type of clot busting drugs that we have. The important thing is to give one of them. Give one of them. You have streptokinase, alteplase, eretinoplase, and tenecteplase. So these are different, what we call fibrinolytic or thrombolytics. Okay, so you need to, if you're in a facility that can't do stent, in a country that can't do stents, then you need to have some of these. Okay, because it will break up the clots. However, there are contraindication to some of these drugs, so you need to know a little bit about the drug itself. Say contraindication for fibrinolysis and STEMI. If the patient had any prior or previous intracranial bleed, any bleeding in the brain, you don't want to give it. If they have known structural cerebral vascular lesion, we commonly talk about arteriovenous malformation in the brain, you don't want to give it. If they have known malignant intracranial neoplasm, any type of cancer in the brain, you don't want to do it, whether it's primary or metastatic. The only exception is, we use thrombolytics to treat acute stroke, but we have to get the patient within 3 hours. Okay. If you suspect aortic dissection, you don't want to give it, because when you give these medicine, the patient's going to bleed like a pig. So you have to make sure they have no bleeding problems, such as active or bleeding diaphysis. You don't want to give. If you want to see someone bleed to death, then you can give these medicines. All right. So so know a little bit about your thrombolytics. In addition, once you give thrombolytics, you have to give anticoagulant therapy. So you may give heparin. This is unfractionated heparin, or you can give enoxaparin, which is a low molecular weight heparin, and these are some other anticoagulant. But once you give your thrombolytics, because once it bursts, it lights the clot, break down the clot, you're gonna get clotting again. So you need to give your anticoagulant along with it. So you also want to give aspirin or another platelet inhibitor such as clopidogrel. We have Brilinta today. Okay. So it's a lot of information for you guys, but the important thing is to make the diagnosis, okay, and treat the patient appropriately, usually, in a timely fashion. You have to know the difference between, one of the important difference between your STEMI and your non-STEMI is that Your non-STEMI, you never give them fibrinolytics. Non-STEMI patients are not going to benefit from fibrinolytics, only your STEMI patients. So that's an important distinction.